One of the biggest mistakes that healthcare providers make when it comes to bracing adults with scoliosis is many providers try to brace adults the same way that they would brace children or adolescents. And what causes scoliosis to progress in adolescents is completely different than what causes scoliosis to worsen in adults. Additionally, the spine of a child or a growing adolescent is completely different than the spine of an aging adult. So while we treat these with the same types of treatments, how we use those treatments and apply those treatments needs to be completely different. Hi, I'm Dr. Chris Skubals, the head clinician at ScoliCare Denver and leading specialist in the non-surgical treatment of scoliosis and hyperkyphosis. And one of the most common questions I get is, can bracing be effective at treating or helping adults with scoliosis? And the answer is absolutely yes, but we have to know when and how to apply it and when it's most appropriately used. So in this video, I'm going to answer 3 common questions, which is 1, when should bracing be used or when is it appropriate to be used in adults with scoliosis? 2, can scoliosis curves actually be reduced in adults? And 3, how long do adults need to wear bracing or wear a brace if they have scoliosis? Now, if you're watching this video and you're an aging adult and you want to learn more about treating scoliosis in adults, click on the link below in our description and download our free ebook called Scoliosis Knows No Age Limit. So when exactly should bracing be recommended for adults? And that really comes down to what the patient's experience and what their overall goals are. Now, the main reasons that adults with scoliosis seek treatment are 1, for pain relief, to stop or slow progression, to potentially reduce the size of the curve or improve their posture or have improvements in physical appearance or aesthetic improvement, and then ultimately to enhance quality of life. Now, pain is one of the most common reasons, if not the most common reasons, adults typically seek treatment for scoliosis. And the Scoliosis Research Society says that pain of a scoliotic curve of any size, whether in an adolescent or an adult, is an indicator for bracing treatment because bracing can be very effective at helping reduce pain. So if you're an adult with scoliosis and you also have back pain, then bracing is likely a treatment that can be applied. Now, when we think about pain in adults, typically adults will get pain on the side of the curve. The pain is typically at the worst at the peak or what's called the apex of the curve. And a lot of times adults will get pain when on the back or their side of the leg. There's generally more pain with prolonged sitting or standing. And when curves get more severe, adults can experience what's known as intermittent claudication, which is basically pain in the legs or feet when someone starts to walk. So pain is a primary driver. Now, another reason for people to seek treatment is to stop or slow progression. And so when we think about stopping or slowing progression, we want to know how likely it is for a curve to progress. And probably the biggest indicator that a curve is going to continue to progress is a history of curve progression. And this can be determined by looking at previous x-rays to see if a curve have changed over time. So whenever a curve has changed or worsened over time, we know those curves are almost certainly going to continue to get worse without treatment. So in those cases, bracing is almost always an indicated or appropriate treatment. Now, if we don't have prior x-rays and we can't necessarily demonstrate curve progression, then we want to look at, other prognostic factors or predictors that a curve will progress. What's interesting is a lot of providers tend to think that when a child is done growing and they have an idiopathic scoliosis, a lot of providers think that those curves do not tend to progress. But recent research actually shows that 68 to 70% of all teenagers that have scoliosis, that those curves tend to progress or continue to progress after skeletal maturity or in adulthood. So what are some of those predictors that those curves will progress? One of those is the size. And when a curve gets beyond 30 degrees, that's when it has an increased likelihood of progressing in adulthood. That's also a number where it's more likely to cause pain and start to impact quality of life and to start to be associated with other health problems. Now, if a curve is beyond 50 degrees, it's a consensus in the scientific world that those curves will absolutely continue to progress in adulthood without appropriate treatment. So 1, we look at the size of the curve. Another thing we look at is the location of the curve. Now, when we're thinking about children or adolescents, curves in the thoracic spine tend to progress more rapidly. But it's different in adulthood, and that's because how curves progress is different in adulthood. You see, in adolescents or children, the spine is actually growing asymmetrical, and we're trying to guide or protect the curve while someone grows. But in adults, it's a degenerative process. And as gravity's pushing down, the spine starts to break down and decay. Now, in the mid-back or the thoracic spine, the rib cage or the bony structure does provide some level of protection. But you don't have that in the lower spine. And because of that, curves in the lumbar, or what's called the thoracolumbar spine, basically curves in the lower half of the body, tend to progress at a faster rate in adults. Also, single curves, especially single curves with a coronal imbalance, tend to progress at a faster rate compared to when there's two curves that are equally balanced. So the location of the curve impacts the risk of or likelihood of a curve progression. So those are some really obvious ones. So let's talk about some things that some general providers may not be aware of. And one of those is what's called a lateral listhesis, where the bone starts to shift off the spine. And that tells us the spine is unstable. Ligaments hold bones together. And when the ligaments can no longer hold the spine together, we know it's lost its structural integrity. And that means it's unstable. And when you have an unstable segment or unstable joints in the spine, we know that the likelihood of a curve progressing is really rapid. Another thing is when the spine sits high in the pelvis compared to low in the pelvis. When a spine sits high in the pelvis, it's actually more unstable. And the way we measure that is by drawing a line across the iliac crest or the pelvic bones. And if that goes through your lowest lumbar vertebrae or your L5, the spine sits higher. And it means the spine is less stable and it's more likely to progress. If the spine sits lower in the pelvis, it's more stable and it's less likely to progress. A way to think about this, if you think someone's tall and skinny and slender, they're probably a little more flimsy and easier to push around. If someone's like short and wide and, kind of squatty, they're going to generally be more stable. I know it's kind of confusing, so I'm going to show you a couple of diagrams that's going to help illustrate what I'm talking about. So as I talked about that lateral listhesis, we're looking at that right here, and you can see this vertebrae is actually sliding off. And when that slides off more than about 6 millimeters, that is considered an unstable segment, and that curve is likely to progress. We call that a lateral listhesis or an Ole listhesis. Ole means there's rotation involved too. The other one we talked about is the intercrescent line. So this is a line right here, this red line, going from one iliac crest to the other. And ideally that would go through the L4 vertebrae because the spine is sitting lower in the pelvis. But if it goes through this L5 vertebrae, that means the spine sits higher in the pelvis and it's less stable. So let me show you some actual x-rays that demonstrate these 2 points. Here's an x-ray right here. You have the bone right here, and you can see that slipping off the edge here, and that's a large lateral listhesis. This one is definitely over 6 millimeters. So this is a high predictor this curve will continue to progress. Another one is right here. This is where we have that intercrescent line, where we draw that line straight across. And in this scenario, it's going through the L5 vertebrae, so that's less stable compared to the L4, meaning the pelvis or spine sits higher in the pelvis, so it's less stable. Now, while I have this previous image up, there's one more I want to talk about. One is when you have severe wedging in the disc. The disc are the cartilage between the bones. And here you can see there's a big opening here and it's really narrow. And so the proportion of the width on the outside versus the inside, there's a pretty significant difference. So there's severe wedging in the disc, and that severe wedging is another predictor of curve progression. Now, the other thing we look at is spinal balance. And ideally, when we look at the spine from the front, your neck or the cervical spine should be lined up right over the center of the pelvis. And when we look at the spine from the side, your ear and shoulder and the lower cervical and upper thoracic spine should be lined up over with the pelvis. When the body starts to translate forward, that's called an anterior sagittal balance. When the body starts to shift to the side, that's called a coronal balance. And when the spine is out of balance, when you're shifted to the side or you're leaning to the front, those are also predictors of pain and disability, but also they increase the likelihood of a curve progressing. To help illustrate this point, let me show you a couple of diagrams that show what I'm talking about. So this is what typically happens in an adult with degenerative scoliosis. They start to get a lateral lean to the side, that's that coronal imbalance, and they start to lean forward when viewed from the side. This really shows what we're talking about. So when you look at the spine, ideally, the lower cervical, upper thoracic should be lined up right over the center of the sacrum. And you can see in this case, the spine is shifted over. That's called a coronal imbalance. And when that gets beyond about 4 centimeters, that's a high predictor of pain and disability and something that will impact patients' quality of life. When we look at this one, there's a line drawn straight down from the center of C7, and ideally that would intersect back here in the sacrum. In this case, that's actually going forward, so that's a positive sagittal balance. And when that gets beyond about 4 centimeters, that's also a strong predictor of pain, disability, something that's going to impact the patient's quality of life, but also a strong predictor of curve progression. And then one last thing we look at that's a strong predictor of curve progression is how much rotation there is in the spine. And the higher or the greater amount of rotation at the peak of that curve or at the apex, the more likely the curve is to progress. So I went over some of the big things we look at, which tells us the risk of curve progression. There's about 9 or 10 things that I typically evaluate when I'm looking at an adult's x-rays that helps determine how likely they are to progress. And I just wanted to touch on a few of those. And any really skilled provider will look at all of those when they're determining how likely a curve is to progress. But if one or multiple of those are present, we know someone is likely a candidate for bracing. Now, can you actually reduce the size of the curve in adults? And the answer is sometimes. What I want you to understand is scoliosis to spine deformity. What we're not changing is the actual bone deformity. When you have scoliosis, the shape of your vertebrae change over time. That part cannot be changed in adults. But in adults, patients are basically at a war with gravity. And as gravity pushes down, the spine or posture begins to collapse. And that postural collapse is what can frequently be improved in adults. Additionally, I just talked about when you have a coronal or sagittal imbalance, meaning when the spine is shifted off to the front or you start to lean forward, that postural or that overall balance can also typically be reduced. But are there things we look for that actually help us predict which curves can be reduced and which curves are not? And the answer is absolutely yes. And the biggest predictor that a curve has the potential to reduce in adulthood is how flexible the spine is. Now, when someone is younger, typically in their 20s or possibly 30s, their spine tends to be more flexible. So most of the time when we see curve reduction in adults or bigger curve reductions, it's when people are younger adults that still have more flexibility. In the 40s, the spine starts to get more stiff and rigid, and as the spine gets more stiff and rigid, it gets more challenging or difficult to reduce the size of the curve. And even in the scientific literature, most of those are on older adults, and it says, yes, we can effectively treat older adults and stop and slow progression, but the treatments be more effective if we treated adults when they were younger and their spines are still more flexible. So how do we determine how flexible a spine is? Well, there's 2 primary ways. One of those is with lateral bending x-rays. This is what surgeons use to also identify how flexible a curve is. And we measure the angle of the curve when someone is standing straight, and then we'll have them bend into the curve, and then the other way too, and we see how much that curve reduces. Now, in an adolescent, if a curve reduces by about 50%, we would consider that flexible. In an adult, if a curve reduces by at least 20%, we would consider that flexible, and we know that there's a chance to reduce some of the size of the curve. Now, other than x-rays, another way we can look at how flexible a spine is by measuring how much their rib humping decreases when they're lying down. So we can measure what's called the angle of trunk rotation using something called a scolimeter. I'll show you. This is a scolimeter, and here you have the rib humping. And we do this forward Adams bending test. You might have had this done by a school nurse or someone when you were in high school when they were checking for scoliosis. And we use this scolimeter to measure how much rotation is the spine. So we can do this when someone is standing and bending over, and then we can also have them lie down on a table. And we can measure the difference of the rib humping when they're standing compared to lying down. And depending on how much that rib humping decreases when someone lies down, that gives us an idea of how flexible they are, and it also gives us an idea if we might be able to reduce the size of their curve. Now, as I previously mentioned, that's looking at the curve, but the other thing we can typically improve in adults is coronal or sagittal balance. So when someone is out of balance and they're shifted to one side, or they're leaning forward, that is something we can frequently improve. And I'm going to show you some examples of that in a second when we go over some cases. Now, the last question I get is how long should adults wear braces? Well, it's a 2-part question. One is the overall treatment, and the other one is how much per day. And research shows if adults wear braces around 4 to 6 hours a day, that's typically enough to decrease pain and stop or slow the progression of curve. But if we have a younger adult and we're trying to reduce the size of the curve, then we'll typically encourage to wear the adults as much as possible, maybe 18 to 20 plus hours a day, just like an adolescent. Now, in younger adults who are trying to reduce the curve, we will typically wear that brace for around 6 to 12 months. And after that time frame, the adults will have the choice if they want to continue to wear the brace or not, because we'll do regular, maybe annual or biannual x-rays to see if the spine is stable. But in older adults that have more severe degenerative scoliosis, most of those adults will wear the brace anywhere from 4, maybe up to 8 hours a day, and they will continue to wear those ongoing as more of like a brace or retainer to keep their spine stable. So big picture, for pain relief or stabilization, probably 4 to 8 hours a day. In older adults with more severe degenerative scoliosis, they will typically wear those braces ongoing. But younger adults, maybe adults in their 30s or 40s, they may discontinue brace wear after the initial 6 to 12 months, and they're probably wearing the brace more short term to potentially decrease pain or reduce the size of the curve. Now, when we combine the bracing with scoliosis-specific exercise, the results are much more stable also when we start to wean off bracing. Now, back to the original point, can we actually reduce the size of the curves? And yes, in many cases we can. So let me go over some examples or cases where we've actually shown or achieved pretty good curve reduction. This first is a paper looking at older adults where they're using custom scoliosis braces for pain reduction and to stop progression of curves. And they said that, the braces overall are really well tolerated and they get good results, and it's a really good option outside of surgery. This is the overall results of the study. These are adults that develop scoliosis as an adult. Those are degenerative scoliosis. Those scoliosis curves are typically more aggressive, and on average they progress at about 3 degrees per year. Idiopathic scoliosis, the one over here, these are the people that had scoliosis when they were younger and they still have it in an adult, and their curves typically do progress but about 1 to 1.5 degrees per year. So in this study, they watched the patients over 15 years. And for the first 10 years, they had no treatments at all. And that's the black line right here where you see this line going up. That's actually the curve progressing. More steep in the degenerative scoliosis, the scoliosis that started in adulthood, and more gradual in the idiopathic scoliosis. Then where the line changes from black to gray, that's when they had the patient start wearing the braces about 4 to 6 hours a day. And where you see the line actually start going down, that's because there was a reduction in the curve. And you notice in all of these, either the curves reduced or the rate of progression changed. And when we look at all the patients in the study, over the first 10 years, the average patient's curve got 15 degrees worse, or 1.5 degrees per year. And then when they had them start wearing the custom bracing 4 to 6 hours a day, the average person's curve over the last 5 years only got 1 to 2 degrees worse, or about 0.1 to 0.2 degrees worse per year. So the conclusion is bracing is highly effective at slowing the progression of curves in adults, and in some cases can even help reduce the size of the curve. Now, I mentioned adults that are younger and more flexible have a higher likelihood of curve reduction. This is one of our patients. This is when she came in. You can see her spine is flat here and more indented. That's because she has a scoliosis here. This is her in her brace, putting her in an opposite position. Her curve was initially 52 degrees. She was recommended surgery. She was a young adult. She had pain with sitting or standing. She couldn't lift for more than 5 pounds, and her pain was so severe she almost couldn't even work. And she was told she had to have surgery. Nothing outside of surgery would help. That's what her orthopedic surgeon told her. She came to see us, and we prescribed a custom brace and scoliosis-specific exercise. Now, she was very compliant. She wore her brace over 18 hours a day, and in just 3 months, we reduced that curve from 52 degrees down to 34. That's a pretty big improvement. More importantly, she has no pain, she exercises, she lifts weights, and she's even working out with a personal trainer now, and it completely changed her life. But her curve is very flexible. Here's another case with a young adult. She had a 44-degree curve. She's in her 20s, and she was told she needed surgery as well. She was actually denied being in a ballet because she had a lot of spine deformity. But she came and got a Scoli brace, and you can see the big difference in her body before and afterwards, and her coronal imbalance. And this is 12 months with her brace off, and her curve reduced from 44 down to 29. Again, a young, flexible adult, those are the ones we most likely get the curve reduction in. And then one more. This was a young adult and is about 24 years old. He had a kyphoscoliosis brace. He had a huge coronal imbalance. Here, this is his initial photos, his posture. You can see his spine shifted off to the left. This is the brace we made for him. This is his out of brace after 1 month. That's with the brace on. And this is his initial. Was February 2016. And this is just 6 months after wearing the brace. So huge changes in his overall posture and scoliosis. Both his scoliosis and his hyperkyphosis reduced. This case was actually presented at a research conference, and this case is actually published in a peer-reviewed journal. And then lastly, I want to look at an older adult with a more severe degenerative scoliosis. This is the initial x-ray here on the left. You can see her spine is shifted over 143 millimeters. And after just 3 months of treatment, the 143 millimeter shift is down to just 90 millimeters. There's more work to do. We may not get that to 0, but even in older adults that have more severe scoliosis, we can be effective at reducing some of those postural imbalances and reducing pain. This person right here, when she started, she was miserable. She really, couldn't almost do anything. Her life was getting very hard to do. She couldn't take care of her kids. And here she still has some pain, but it's much more manageable and she can do all of her normal daily activities, and it completely changed her life. So to summarize, bracing can be effective to treat adults with scoliosis in both adult degenerative and idiopathic scoliosis. But how we go about bracing in adults is completely different than how we brace in adolescents, because how the curve progresses is different. Also, a spine of a growing adolescent or child is completely different than the spine of an older, possibly geriatric patient. Now, there are many things we look at to determine if bracing can be effective. Both pain, the risk of progression, the patient's goals, what they're trying to achieve. There are several different things we look at. And adults will typically wear a brace 4 to 8 hours a day for pain reduction and stabilization and reduce the risk or the severity of curve progression. Young adults, we may be able to reduce the size of the curve, so they may wear the braces more, up to 18 to 20 hours a day, but they likely won't wear those braces long term. In older adults with severe degenerative scoliosis, they're probably going to keep wearing the braces a few hours a day ongoing to really put the brakes on or stop or slow the progression. Now, if you're watching this, you're likely an adult with scoliosis, and you're probably wondering what you should do. The first step is I'm going to encourage you to click on the link below and request a free discovery call. That's going to give you a chance to talk to me one-on-one about your scoliosis. I'll let you know the severity, how likely it is to progress, and what treatments you're a candidate for. And to learn more about the most effective treatments for adult scoliosis, click on our next video, and I'll see you there.